Well, hey everybody, it's your boy, Dr. Mark List, coming at you with another episode of the Primary Care Podcast. But before we do that, we're going to start with the primarycarepod@gmail.com inbox for a joke from an anonymous listener. The primarycarepod@gmail.com is where you can send any questions, thoughts, feedbacks, anything that you want to talk about or want to hear on the podcast. Love to hear about it. Or if you have jokes to share, I've had many listeners now share jokes. This comes from an anonymous listener. Dr. List, why does the Norwegian Navy put barcodes on their ships? Why does the Norwegian Navy put barcodes on their ships? Answer: so that they can Scandinavian. Oh, I love it. All right, let's start the pod episode.
The Primary Care Podcast is written and edited by a family physician for an audience of other physicians, nurse practitioners, physician assistants, residents, and medical students interested in primary care topics. This is not a podcast for patients and should not be used as medical advice. This is also a personal podcast produced on my own time and solely reflecting my personal opinions. Statements of this podcast do not reflect the views or policies of my employer, past or present, or any other organization with which I may be affiliated.
Thank you for listening to the Primary Care Podcast. I'm Dr. Mark List, here to bring you the latest news, guidelines, and updates from primary care sources around the globe. Keeping it under 15 minutes long because you're in a hurry and I'm not that smart. Hey everybody, welcome back, pod girls, pod boys, pod people, to the Primary Care Podcast. I'm your boy, Dr. Mark List, here with you at another episode of the Primary Care Pod. You can reach us at primarycarepod@gmail.com, as you know. Today we're going to be talking about a new treatment for Alzheimer's disease. It's a monoclonal antibody called donanemab. Donanemab. Okay, I could do this all day. But it's a monoclonal antibody, which we're going to call DANA, and donanemab. DANA is a treatment that is a IV therapy like all monoclonal antibodies, or at least most of the monoclonal antibodies. And it's an experimental drug, and it has been shown recently in March to have positive results in Alzheimer's disease. So we're going to talk about the study that was in Journal of American Medicine. It was in, let me pull up the exact date here, March 14th in JAMA. Sorry, not JAMA, New England Journal of Medicine. How dare I? New England Journal of Medicine. And the treatment basically was to try to slow progression of Alzheimer's disease in patients with mild Alzheimer's disease. And they followed these patients for 6 years, 6 1/3, actually. It was just over 6 years. And so as they followed them, they checked several different things. Now, a couple things to note is that they excluded a lot of patients from this study because of lots of different reasons. But majority of the reasons were people were either did not qualify from a mini mental exam standpoint, or they did not have any tau on their PET scans. And this antibody specifically targets tau to help remove these amyloid-specific plaques. So when they talk about the study dynamics, right, they did these monthly injections of this monoclonal antibody, and then they followed patients. And they looked at a bunch of different testing, primary outcomes, secondary outcomes, and a lot of them were, for example, the secondary outcome was the mini-mental. There was another cognitive assessment. The primary outcome was the patient's disease progression, right? And so they used a scale which I have not personally ever used or seen used clinically, but apparently in research it is used. But this score is called an integrative Alzheimer's disease rating scale, and the scale ranges from 0 to 144. And so during this study, they followed patients and they saw a clinically significant difference in the progression and the slowing of Alzheimer's disease. Now, you don't come here for that type of information. You come here for my opinion on things. It was important to know that this scale is, again, a scale of 144, okay, 0 to 144. And patients at baseline had a score of about 106, okay? Now, the baseline change in the placebo group was 10 points, okay? So if we did absolutely nothing, just let patients continue to decline over 6 years, they had a 10-point drop in this scale. And it was only 6.8 with this monoclonal antibody, donanemab. I'm just going to stop. So after 76 weeks, so they gave these patients monthly injections, 76 different injections, and they saw a clinically significant difference. The p-value was 0.001. 0.04. Again, clinically not significant difference would be insignificant difference would be if it was or there was no clinical significance would be at above 0.05. So this was 0.04. And the confidence interval was quite large, 0.12 to 6.2, and the difference being obviously a difference of 3.2 in that scale. So again, what does this mean? This is a monoclonal antibody that we gave monthly injections, which is incredibly expensive. The secondary outcome showed a massive reduction in these plaques with PET CT scans of these amyloid deposition, so significant removal of these plaques. So secondary outcomes were positive. That was the only secondary outcome was positive. The mini-mental did not change, was not clinically significant. There was a 0.6 drop in the mini-mental between the two groups, worsening in the placebo group, but that was not statistically significant. I imagine that they stopped the trial at 76 weeks because they finally hit clinically significant difference in the change of baseline IADRS, right? I don't want to be a cynic, but I'm assuming that that's the reason why they went to exactly 76 weeks and not 72 weeks and then stopping, right? Or things like that. I'm sure that it was because they finally hit clinically significant change so they could stop the study and say it was positive. And overall, what did we get? Well, we got a great reduction in plaque. We had increase in the number of side effects in regards to cerebral edema related to these basically removal of these plaques. So some patients were probably harmed by this. Now, were the treatment group benefited? Did they benefit in a 3-point reduction in a 144-point scale? A 3.2%, a 3.2 point reduction on the 144 scale when they started off at 106. It's statistically sure they were benefited based on the study statistically. Clinically, does a 3.2 difference on a 144 point scale over the course of 6 years, over 6 years, amount to anything? No, I don't think any of us looking at it that way would say that this was a positive study. And yet, of course, right, this is hailed as a positive study, a first step in the treatment of monoclonal antibodies. WebMD, right, the day after the study showed new Alzheimer's drug slows cognitive decline in an early test. An experimental drug appeared to slow cognitive decline in people with early Alzheimer's disease, according to new published research. The drug donanemab is an antibody that targets and removes plaques from the brain called amyloid beta, which are thought to play a role in Alzheimer's disease. And compared to people in the study who got placebo, people who received donanemab showed 32% slower cognitive decline over a year and a half, according to studies published. So I find it interesting, right, when they talk about a 32% relative decline. Again, because instead of a 10-point drop, they had a 6.8% drop, a 6.8, not percent, a 6.8 drop on this scale compared to a 10 drop on the scale of 144. So, and then they go on to the neuroscientist and the chief officer of Alzheimer's Drug Discovery Foundation, who's quoted that the result is relatively small, but the early study gave a signal that there might be a modest cognitive benefit. Oof. Okay, so your patient's going to be reading this trial who are going to be seeing this data about Alzheimer's disease and there's potential treatment, and they're going to want to be enrolled in studies, and they're going to want to undergo this monoclonal antibody because Alzheimer's disease is terrifying. As somebody who has a huge family history of Alzheimer's disease, as somebody who's seen patients, especially with early Alzheimer's, everyone is hoping for a cure. We're all hoping for treatments, and all of our current treatments are pretty much garbage. We can talk about all the oral medications we want, whether or not they do much, whether that slowing the decline is meaningful, whether it's all placebo. It's horrifying. It's hard to deal with, and it's hard to watch our patients struggle and fade off into nothingness. And this study, again, hit clinical statistical significance based on some obscure 144-point scale after over 6 years of treatment, which they can tout as a 32% reduction in cognitive decline, even though we all know, looking at that as concrete facts, that that's clearly not an accurate assessment of the study. So unfortunately, the search goes on for decent Alzheimer's disease treatments. It's important that we actually look at these studies, because I'll tell you, I even signed up for a couple of mailing newsletters, not for Alzheimer's disease drugs in particular, but in terms of just overall, people that do, like Journal Watch, for example. I have they send me the emails every once in a while, which is no surprise because a lot of times they'll have a pretty up-to-date studies. One mailing list that I signed up for a long time ago, which I still get, is called, actually, you know what? I'm not going to mention it. They're not a podcast. They're not anything. It's just a newsletter, and they have ads in the newsletter, and that's how they pay for the revenue for it. And the week that this study came out, they talked about mega trials in Alzheimer's disease. They basically, in this trial, talk about this takeaway that these results look a little sharper than other trials than prior Alzheimer's phase 2 studies. The field will be watching closely for phase 3 trials. And I think that it's important to note that this trial is complete and total garbage. It clearly has no clinically statistical significant impact on patients, on treatment outcomes. And people see the headline, they see the results, they don't dig into the details, they don't actually read the studies or look at the data. They see the headline and they move on. They read the part of the abstract and they move on. And this is a case where this trial is garbage. It is done to, obviously, they stopped again, the cynic in me says they stopped as soon as they got statistical significant difference, and they could tout some percent reduction in cognitive decline in some scale that we don't use clinically, even though the mini-mental and other scales that they use that we do use clinically were not statistically significant. They show that, yes, look at all this plaque that we moved out of the brain in PET scans. And so the secondary outcomes look impressive. But that hasn't shown any modest cognitive benefit. There is no cognitive benefit in these trials. A 3.2 point difference on a 144 scale, 144 point scale. That's clearly not clinically meaningful. And yet this will go on as a positive trial. It will be used to further justify this drug. And the cycle continues of patients probably being harmed more than they're benefited. And nihilistic medicine somehow rules again because we can't accept negative trials. So, frustrating but important look into Alzheimer's disease treatments, this blockbuster drug, which, again, got press in WebMD and a lot of even mailing lists and got made some circles this last week or this last month. And again, disappointing. But hopefully today was a good, basically journal club introduction to this topic or this drug. Hopefully there's good takeaway points of don't be fooled by the press. Make sure you read the study or have somebody else read the study and let you know what it looks like. And hopefully again today prove that you don't need to stay up all night to stay up to date. Please have a great week, and I'll see you next week. Thanks. Bye.